Thank you very much, Dr. Kindig and Dr. Isham. It's certainly a pleasure for me to be here today at this inaugural meeting, something I think a lot of you I know have been working towards for a long time, and so it's gratifying to see it finally all come together. Apologize for my voice. I was the victim of grandchildren. But so far, so good. Well, I have a clicker. I'm going to just ask you to advance the slides. So, let me start by a few of the main points. I think one of the most important things is we all have to come together and understand what our goal is. And the goal isn't all that complicated. Many of you have articulated before. It's about long, healthy lives for all. And the for all is critically important, since it's not just about long, healthy lives, but it's about equity and closing disparities. The second point, which I'll go through in a little bit more detail, is that if we want to have healthy people, we've got to have healthy communities, because it's the healthy communities that produce healthy people. What I'm going to be spending most of my time on this morning, though, is about how we reframe the debate on our investment in health, and understand that we in this country are paying an enormous opportunity cost for the choices that we've made, perhaps not explicitly, but implicitly, and that we have to find ways to express that opportunity cost in ways that are meaningful to the people, so that we can get them to embrace the kind of change that we're talking about. And the last point is that we've spent a lot of time describing the problem. Many of the people in this room have been extraordinarily articulate about what that problem is, but we actually need a broad portfolio of effective interventions, and we need the data to show which interventions work, and to be able to talk about how we're going to allocate our resources in better ways, so that we're going to have more effectiveness and better health outcomes next. So, the first point is that if our goal is long, healthy lives for all, then we need to measure it. And in the report that David was referring to, we talk about the fact that we need a standard measurement of health-adjusted life expectancy, or what I just call healthy life expectancy. It's a simple concept, a lot of difficult arithmetic behind it, but it's a concept that everybody can understand. And if we start using terminology like this in consistent ways, it'll have as much currency as other things that people don't understand, but they know what they mean. With like gross domestic product, consumer price index, people understand what these things mean, and we need to be able to articulate these things clearly. Next. As I said, healthy communities produce healthy people, and the community's health is more than the sum of the health of individuals. And we've tended to measure health in terms of the health of individuals, but it's important we understand what a healthy community is. Next. I happen to like this formulation, which comes from Linda Rudolph and her colleagues at the Strategic Growth Council for the state of California on the Health and All Policies Task Force. And you should know that former Governor Schwarzenegger created this as the economic driver for the state of California, and saw health as an essential component. And they describe what a healthy community needs to be. And it's not all that complicated. It's really what people want. It meets the basic needs of all the people in terms of transportation, providing healthy foods, affordable, safe housing, high-quality health care, complete and livable communities through schools, parks, recreation, libraries, and many other services. It basically meets everybody's daily needs. It includes a quality and sustainable environment and adequate levels of economic and social development. It's characterized by social and health equity and social relationships that are supportive and respectful. I think those are things that everybody can relate to. But I'm not going to spend a lot of time there. I'm going to talk primarily in the few minutes that I have about opportunity cost. And many of you know these data. The U.S. spends about $2.7 trillion on medical care, 50% more than the next highest country. And we know that that's just an open-ended, poorly controlled spending which functionally takes resources away from other goods and services, which can provide us much greater value. Next slide. And the careful review of an IOM committee a couple of years ago showed that of that $2.7 trillion, some 30% is waste. That's $700 to $750 billion a year in wasted healthcare costs. Next. I'm not going to go through all of this, but this is what the committee found was the source of that waste. And I'm not going to pretend like it's easy to get rid of that waste. It's not, but that's not my task today to tell you how we're going to get rid of that waste. What I really want to talk to you about is what we could do with it. And I come to this usually an ecologic model, and I particularly like the formulation that David Kindig and his colleagues have at the University of Wisconsin. And this should be familiar to all of you, since you've probably seen it many times as part of the county health rankings. And it looks at the health outcomes at the top in terms of the product of morbidity and mortality, but most importantly looks at the health factors, which take up the bulk of the things on the right-hand side of the screen. And aside from the specific indicators, which I'm not going to go into here, the most important takeaway message for me in all of this has been the relative balance of the four indicators. And you can see them here in the medium blue boxes: the health behaviors, the clinical care system, the social environment, and the physical environment. And perhaps most importantly, the social environment, physical environment accounting for approximately half of the factors that drive health, and 30% due to health behaviors. And in fact, the clinical care environment, while it is important, accounts for only 20% of our well-being. So I see Dr. Feinberg. Do you want me to keep rolling? Sorry to preempt you. But the message is that healthcare-related spending crowds out expenditures on social goods, and you know what they are. They are the major drivers of health, education, economic development, and critical infrastructure in this country. Next. This slide from Elizabeth Bradley shows what the U.S. spends on social services and medical care compared to the other OECD countries. And as you can see, the U.S. is circled here. We're not that far from the median in terms of what we spend on these things. But if you look at the dark bar, which is the medical care, you can see that we are definitely an overachiever. And that while other countries spend over twice as much on social services as medical care, we spend less than 1 time as much. In other words, we're taking money from some general public goods, common goods, and devoting them to clinical care services. And we're paying a price for that. So what Jonathan Fielding, my boss, and some colleagues at UCLA did, we tried to say, okay, if you take that $750 billion that we waste every year, what could we buy? And what we really wanted to say, what could we buy in terms of health? And as I go through a number of these examples that you'll see some of the things that we could buy, but you'll also note that the data for some of these things is not as robust as it should be. And we need to make that data a lot more robust so that we can actually make the case much more strongly about the fact that many of the interventions I'm going to be talking to you about, and others for which we couldn't find much data, provide much greater opportunity. Oh, go back. So if you look at that, the $750 billion in waste, about 55% of it accrues to the private sector, or over $400 billion a year. And the remaining 45% accrues to the public sector, which is something over $330 billion a year. Next. And getting rid of that waste, as you know, isn't going to be easy, but what if we could, next slide, eliminate that wasteful spending and used it for something more positive? So let's look at that. So on the private side, $412 billion could be saved every year. And that can be used to increase business investment, add jobs, increase our international comparativeness. It can bolster our economic growth. And it can be actually just given back to people. That's $1,300 a year per capita in increased income. So overall, that could have a significant impact on not only our economic well-being, the quality of the private sector, but increasing our living standards. And now let's look at the public side. There's $338 billion there, and I'm going to divide this into three components. Using that money for fiscal health, our failing infrastructure, and improving the population's well-being. Next slide. So here's one scenario of what we could do with that money. If one is to devote 50% to federal fiscal stability investment, 30% to social investments, and 20% to infrastructure. You can divide that up in other ways, but this is one way that we chose to deal with that. Next slide. So if you look at that fiscal stability, that's $168 billion annually. If you all recall the super committee that a couple of years ago was asked to come up with $1 trillion, or $1.5 trillion over 10 years, there it is. $1.7 trillion over 10 years that could be used to achieve fiscal stability if we devoted 50% of the waste in the healthcare system simply to getting our fiscal house in order. Next slide. If you look at the social investments for $104 billion, 30% of the amount. Next slide. We could do lots of things, and I'm going to run through these quite quickly because it's a long list, and I understand these slides will be posted, so you'll get to see them quickly, get to see them in more detail. $53 billion could decrease our class sizes and increase our graduation rates by something like 100,000 per year. Next slide. And Steve Wolf is, I don't think, going to be talking about this later, but you can see what that would do in terms of the additional money that would become from over a lifetime of graduates in terms of taxes and other revenues. So in addition to the increased revenues that would come from increased graduation rates, every dropout costs us close to $300,000. Next slide. For a mere $100 million, we could prevent 300,000 students from smoking by giving them smoking prevention education. Next slide. Regular home visits from nurses would cost about $4 billion annually. We could get about 700,000 additional visits for pregnant smokers and pregnant teens. Could reduce low birth weight by about 35,000 and reduce ER visits by over 435,000 in the first 2 years. Next slide. Social development programs for first grade students would be about $14 billion, and could decrease risky sexual behavior and drug use, as well as improve social and emotional function. Next slide. Head Start, $13 billion increased annually, could double the number of children who are enrolled, with a reduction in, of course, obesity and smoking prevalence and other benefits associated with Head Start. Next slide. Universal preschool, again, get these kids off to a good start, leads to long-term gains in cognitive ability and socialization. Next slide. Teen pregnancy prevention, $1 billion, could prevent some 40,000 teen pregnancies every year. Next slide. So there's a lot on the social side. On the infrastructure side, there's about 20%. I'll go through a few of these as well, quickly. The direct and meaningful benefits for individuals and communities occur when people live in healthy communities that have healthy environments, clean air, green spaces, complete streets, affordable, safe, and accessible parks, and so forth. Next slide. In Charlotte, North Carolina, simply putting in a light rail was actually shown to decrease obesity, 1.8% point reduction in body mass index, and reduce costs of being obese over time. 30 years ago, 2/3 of kids walked to school. Next slide. And today, only 13% do. Next. A Safe Routes to School program would cost $1.2 billion annually. And these initiatives have shown as much as 30% more students walking or riding bikes to school and other vehicles, and decreases in congestion. Next slide. Improving drinking water could be accomplished for about $2 billion a year. Next slide. career training, about $18 billion annually, would improve vocational and technical training. There we go. And obviously these individuals have great career prospects and increased wages. And the last slide just has a few closing thoughts here. First and foremost, there's a large opportunity cost of wasteful health care expenditures. And we have to have a way to express that in ways that are meaningful to people and help us drive change. These changes are going to require difficult decisions, and politically difficult reforms need to be made. And it's going to require building some strong constituencies across many sectors to drive this forward. We need to invest in the evaluation of health impact of interventions. I've given you some of the work that we've done in these examples, but I can tell you the data are spotty. We really need a more sophisticated set of methods and a much greater investment in understanding what the health impacts are of all of these intersectoral interventions that many of us feel are critical, so that we can make a much more solid case. So we need new methods, and we need to devote resources to doing that. And finally, there are really tremendous gains that can result from redirection of resources, and that we need to bring together those with common interests and effectively drive the kind of systematic change that we're here to accomplish. So with that, I'll end. Thanks so much.
Well, thanks so much, and for somewhere starting us on this focus about the health dividend and the uses that we can make if we can really identify those resources. So we'll return to that later this morning and in all of our work. So it's a total personal pleasure to introduce Harvey Feinberg to come up and sort of give us some kickoff remarks for our work for the next 3 years. And we're sort of in his house, so that's appropriate that he do that. As you know, Harvey's the president of the Institute of Medicine, serving in that role since 2001, having come here from roles as the Dean of Public Health at Harvard and Provost of Harvard University prior to that, and all of his amazing academic work in health policy and medical decision-making. On a personal note, some of you know that we have one of the sites at Wisconsin of the Health and Society Scholars Program, which is the Robert Wood Johnson postdoctoral program. And for 10 years, Harvey served as chair of our advisory committee. And it was in that time that we actually developed our friendship. And I can't tell you what he brought to that program in terms of not only understanding the science of what we're about to the degree that it exists, and as Steve mentioned, we have other ways to go, but actually this really sensitivity to the policy opportunities and challenges and the humanity that he brings to everything. So Harvey, thank you very much for joining us.